Okay, good afternoon everyone. Welcome to our July WebEx, which is part of our SPSP Medicine's monthly WebEx series. It's really great to have you all along today. As a programme, one of our priority areas is high-risk medicines, and this WebEx is focusing on insulin safety in acute care. We're delighted to have Debbie Boyd from NHS Tayside and Steve Cleland from NHS Greater Glasgow and Clyde presenting today, and we'll be hearing from Debbie and Steve very shortly. Just a few points to be aware of for the WebEx today. On screen now is the audio connection information for anyone who has connected to the WebEx only and still needs to dial in. For those of you who aren't presenting, so have joined us today as participants, your lines have been muted, but we will be opening all the lines after the presentations to allow for questions and open discussion, and we really hope that you will join in with us. While your lines are muted, we would really encourage you to use the chat box function to introduce yourself, so let us know what you do and where you work. And please make sure that you select everyone from the options list when you are sending your messages so that everyone can see and reply to your comments. We are recording today's WebEx, and a link to the recording will be posted on our website. So if you're listening to the recording, thank you, and we hope that you enjoy the presentations. A few introductions before we begin. My name is Lorraine Donaldson and I am the Project Officer for the SPSP Medicines team. In the room with me today I have David Maxwell, our Improvement Advisor, Arvind Brea, our Clinical Lead, and Kirsty Allen, our Administrative Officer. So before we get started with the presentations, it would be great to learn a bit more about who we have joining us today. So I'd like to ask you to join in our quick poll. The polling question is, which of the following professions best describes you? And the options are A, patient or service user, B, medical, C, nursing, D, pharmacy, and E, other. So we'll just open that poll for you to make your selection. If you do choose other, please pop over to the chat box and let us know more. We'll just leave the poll open for a few minutes to allow people to complete it. Thank you. Let's leave it open for a few more moments. Okay, thank you. We'll close the poll shortly and we'll post the results for you to see. Just bear with us a few moments. Okay, so you can see the poll results on the right-hand side of your screen now. So it's great to see that we do have a range of professions joining us today and a number within our pharmacy colleagues. So without further ado, it's my pleasure to hand you over to our first presenter for today, Debbie Boyd from NHS Tayside. So thank you, and over to you, Debbie.
Good afternoon, everybody. I'm going to speak to you today about insulin safety in acute care, and I'm going to home in on subcutaneous insulin management. We've recently updated our IV insulin guidelines. I'm going to speak to you about our new insulin chart, which we implemented a year ago just now. So next slide is a picture of me. I'm a diabetes specialist nurse, and my main role is inpatient care. I'm the national lead diabetes specialist nurse in the Scottish Diabetes Group, and I also sit on the TREN group, and that stands for Training, Research and Education for Nurses in Diabetes, which is a group who provide competencies about diabetes nursing and general nursing and guidelines about how to manage diabetes safely, and also do some teaching for the University of Dundee. That's my email address there, which anybody is welcome to contact me regarding anything they hear in this presentation. Next slide. To put into context NHS Tayside, we have about 300 people with diabetes in our hospital beds. We're about 1,200 bed hospital, so around about 20 to 25% of our population of inpatients have diabetes. We've got a significant elderly population, which will be the same in all hospitals, and there's a significant number of patients treated with steroids, also things like enteral feeding, which means that we have a lot of people who are treated with insulin, albeit on a short-term basis. We have quite a number of episodes of hypoglycemia, around about 400 per month, and I'll give you a bit of data feed from that. Next slide. The background to our improving our insulin chart was we had implemented a new insulin chart in 2006, but it's kind of outgrown its useful function. It was too small. It was only one page of an A4. We realised that we didn't have a lot of space, so we had illegible handwriting. We didn't have pre-printed units on the chart, so we got some abbreviations of I and U, or U, which could be easily misconstrued as a numerical value. We had spelling errors for insulin, insulin omission, transcribing errors, in particular in relation to things like humulin M3, humulin I, humulin S. And we appear to have a lack of knowledge about insulin. People probably scared about insulin because there's so many different preparations. And we knew that the management of hypoglycemia could improve. Also, there was some concerns about hyperglycemia. So we knew all round there was a need for improvement. So next slide. We utilised improvement methodology. Ideally, we wanted safe, legible, patient-centred prescribing of insulin in hospital wards, reduction in errors, and we wanted to improve the design of our insulin prescription chart. So we did we introduced things in small numbers and small areas. And if you go on to the next slide, the bigger picture was that initially we designed an insulin prescription administration record, which we lovingly called the IPAR. We tested the IPAR in one ward with one patient, with one pharmacist, with one doctor, and built up from there to several wards. It's difficult to pick a ward because you don't want to pick an admission ward where patients go right the way across the hospital. So we initially tested in our renal ward because a lot of people came in, went directly to the renal ward, and we felt that was a safe place to test. And clearly there's a lot of people who are treated with insulin in the renal ward. We measured the compliance with key targets, which I'll show you. We looked at patient engagement using the insulin administration tool, and then we went to implement across the organisation. That was probably the trickiest part of all. Next slide. We looked at patient staff satisfaction in our test ward, and this was just a piece of work that I reported on, and it was really getting information about how satisfied the staff were with the new insulin chart, and the results were favourable. Most scored quite highly out of 5. Next slide. And as a matter of just going around the hospital wards, as inpatient nurses, we took a copy of the design of the new insulin chart, and we engaged with as many people as we can, and this is feedback from 100 healthcare professionals. So the IPAR design proved popular, the guidance within it proved very useful. We knew that people could access information online, but we found out that people, although they knew there's information about insulin and insulin management online, it wasn't easy to access it during working hours. And we knew from a previous project of our IV insulin guideline that bedside guidance is very beneficial because it's there at the time of need. Next slide. So this is a picture of the IPAR. It doesn't portray very well, and there's a lot of detail on it. And essentially, this IPAR is in pink, although it's portrayed here in white. We went from a one-page document for insulin prescription chart to 4 pages, and on this document we've got 16 days of insulin administration. We've got room to write 12 doses of insulin plus insulin pump therapy. So we'll look at the sections individually now. So if you go to the next slide, please, Kirsty. So this is probably the most popular part of the IPAR. It allows people to take some of the mystery out of insulin preparations, and essentially what we advertise is there's 3 main types of insulin: short-acting, long-acting, and mixtures of insulin. Because if you say to people there's around 30 insulin preparations, people immediately think, my goodness, I'll never understand it. The time-action profile of the preparations is useful when you're trying to explain insulin time action. It allows the prescribers to spell the insulin preparations because all most of the names are there, although the newer insulins are not, and identify suitable alternative preparations. For example, if somebody comes in to hospital on Humalog and there's no Humalog in the pharmacy, Novorapid or Apidra would be a useful alternative until the routine insulin can be found. We had to pay a copyright to use this diagram, but it's been very well worth it. Next slide. So within the front page we give prescribing information, just a very simple guidance if a routine insulin is unknown, and that helps the new prescriber if a person can't tell what insulin they're on when they come into hospital. And the next slide. So further down the front page we have a good area to prescribe insulin. We prescribe insulin on admission to hospital and then only change it as necessary. I know in some hospitals the prescribing on a daily basis. We feel that this risks transcribing errors and we'd never get insulin prescribed. So insulin is prescribed and changed if there's any concern about the glycemic control. We've got pre-printed units on this chart, so we've solved the problem of people using abbreviations, and there's one line for continuous subcutaneous insulin infusion pumps at the bottom there, so that the insulin can be prescribed there. We have a small section for stat doses of insulin, and what we've added to this from our old chart is asking the prescriber to document the reason why they've prescribed a stat dose of insulin, and this just makes people think about the appropriateness of giving extra insulin. So next page. This is the insulin administration page, and this gives plenty of room for the nursing staff to write down the insulin that they've administered. I think I was in a hospital a couple of years back, and the nursing staff said, why would we write down how much insulin we gave? We just say that we just initial that the insulin has been given on the prescription chart. But what we find is that quite often the dose administered does not match the prescription, because people will change their insulin dose. So I think it's always useful to have how much insulin was prescribed, when it was prescribed, and to what effect, so it matches the blood glucose monitoring. And this is essential information for insulin adjustment. The design of this allows the trends of the blood glucose levels to be checked, so before breakfast, before lunch, before tea, before supper, so that helps with insulin adjustment. And we've also got a space there for hypoglycemia treatment. Next page. We have a measurement which we embed into our care when we're looking at insulin. So is insulin prescribed clearly in capital letters? Is it prescribed on the main drug cardex? Is insulin prescribed without abbreviation, and has it been administered at each time prescribed? This is not the panacea for perfect prescribing, but it's a good proxy measure for safety. So the next slide, please. We've looked at our insulin prescribing, and we regularly do a 40-chart review, which is quite easy because there's always plenty of people on insulin. The left column in February 2017 was before the implementation of our new insulin chart. So you can see since its implementation, the IPAR has shown an improvement in insulin prescribing, which is quite pleasing. And we'll continue doing these audits over time. Next slide. We have a mantra for hypoglycemia management, and that in the event of hypoglycemia in patients treated with insulin or sulfonylureas, was the appropriate treatment available in the ward? Was appropriate treatment given? Was the blood glucose level rechecked in 15 minutes? And was diabetes management and medication reviewed? We still have some issues with hypoglycemia management, which I'll discuss briefly later. And if you go on to the next slide, we've embedded these audits into the insulin prescription chart so that the nursing staff can use this. We use this as an educational tool and also a practical audit that all users of the IPAR can use. Next page. We have a self-administration of insulin guideline within the IPAR, and that's aiming to empower people to self-administer if it's safe to do so, protect the nursing staff who have a responsibility to administer the insulin, allow some governance around insulin administration, and this is in line with the self-administration of medicine policy. So we've got level 1 nurse administration, level 2 supervised administration, and level 3 self-administration of insulin. Next slide. So this is just an assessment tool which is within the IPAR to help the nurses think, is this person currently well enough to self-administer their insulin? Makes them think about a discharge plan. Is this person going to administer their insulin at home? Next page, please. And this is just an outline for you, if you can, read it for level 1, level 2, and level 3. And we've also got a significant number of people who use insulin pump therapy, so it's some governance and guidelines about insulin pump therapy. Next page. Next slide, please. So we got some feedback from insulin administration guidance from just a small number of people in the test site, because we wondered, blimey, was this just another piece of documentation that the nursing staff had to fill? What we felt was it shouldn't be signed, it should be just used as an aid memoir, and we were quite pleased that the information that was given back was that the nursing staff found this quite helpful, and it wouldn't significantly increase their workload if they had to do this. Next page, please. So this is practical advice about insulin administration. This is in with the IPAR also. It's quite a big document. Next slide. And if you look at storage of insulin, in our hospital we have a problem because historically all insulin was stored in the fridge, and we have a problem with in-use insulin devices being stored in the fridge. So we as diabetes nurses have taken on board to inspect the fridges, partly because we discovered the amount of in-use insulin devices in the fridge in the first place, but we still have a disappointingly high number of in-use insulin devices in the fridge, albeit it generally is just 1 pen in each fridge, but there's 8 wards with in-use insulin devices. And the risk about this is that the insulin device can be used for more than one person, so you've got a risk of cross-infection. Next slide. Our insulin pump users, just to let you know that there's national guidance available for insulin pump management in hospital, and that's under review in Scotland to see is that a suitable document for us to roll out nationally. Next slide. We've got information about hypo and hyperglycemia on the back of our insulin chart, and again it's the benefits of bedside guidance as an educational tool and an aid memoir for those people who are familiar with insulin. Next slide. The next 2 slides actually just quickly go through these as our blood glucose monitoring chart, so anybody who's not treated with insulin. Next slide, please. We'll have blood glucose recorded on this, and we have information on the back to cover people who don't have diabetes but are treated with steroid as to checking their blood glucose levels to assess any problems with hyperglycemia. Next slide. We have hypoglycemia information available in hypo boxes. Next slide, please, in every ward. Next slide, please. But what does the data tell us? Next slide. We know that we have a problem with documenting resolution of hypoglycemia, and this was found that this is the same in Lothian and in Glasgow. And we're working towards improving this. We think that hypoglycemia is managed better than our data look, but this is what the data from Sky Diabetes, Track Care and our connected blood glucose meter are telling us. Next slide, and next slide, and next slide. We'll just skip these slides because I think I'm running a bit late. So ongoing work, we're striving to get the basics right in insulin prescribing and blood glucose monitoring, hypoglycemia management. We're promoting the Diabetes Think Check Act e-learning tools. We're networking to share ideas with other hospitals. We've worked with our DATIX team, and we're now going to have a new category of adverse drug event, hypoglycemia. So we're going to ask the nursing staff to report any unresolved hypoglycemia or hypoglycemia that's not been resolved within an hour. And we're always educating the non-specialists, because that's the philosophy of Diabetes Think Check Act, to upskill generalists to look after the 20% of people in hospital who have diabetes. Next slide. Our tea trolley round during Insulin Safety Week proved very popular. We had a box with old insulin Palmer injector devices up to insulin pen devices, insulin pump therapy. We trundled through the wards with our trolley and engaged with staff. Next slide, please. we got very good feedback, and this is really a proxy measure of the benefits of speaking with staff, and they felt that they gained knowledge through the rounds. Next slide. We also promote the Diabetes Think Check Act e-learning modules, which would promote across Scotland. And next slide. We also have our Diabetes Diamond group here, which is in replacement of link nurses, because we didn't think link nurses worked very well. So we have a network of around 100 people who have become Diabetes Diamonds. We meet on a monthly basis, and we network to drive improvements in diabetes care. We're very lucky that a managed clinical network assists with the communication and managing of the mailing list. So the points to take away from this rather hurried discussion: we think that adverse events are underreported. It's only the diabetes nurses going into hospital wards and looking in fridges to find that the fridges are unsafe in many areas. Measurement and audit data are key to evidencing harm and measuring improvement, and our hypoglycemia data is proving very powerful. We want to have, there's an aim to have a national dashboard for hypoglycemia management. Insulin safety also must take cognizance of the patient themselves. They're the most important person, but the nursing staff need to be protected around the governance, around administration, and we need to reduce the risk of complaints and litigation to the health service. Thank you very much, and I'll pass you over to Steve.
Thank you, Debbie. Just as we mentioned, we will open the lines after the presentations are complete, so please keep in mind any questions or comments that you may have. And yes, thank you. We'll now hand over to Steve Cleland from NHS Greater Glasgow and Clyde. Thank you, Steve.
Thanks, Lorraine. And hello to everybody who's joined in with this WebEx. My name is Steve Cleland. I'm a consultant diabetologist in Glasgow, and I chair the GGC Diabetes MCN inpatient subgroup, so I speak on behalf of them, I hope. I'm going to split this talk over the next 20 minutes into three themes: at the tipping point, the tip of the iceberg, and top 10 tips. So to stop you from falling asleep, I'll keep you in suspense about what these mean. So as a background to this, I'm sure it's the same all over Scotland and the UK, the prevalence of patients with diabetes in our beds is pretty high. Snapshot last year revealed 20.9% overall prevalence of diabetes, and 10% of those patients had type 1 diabetes. But you can see from the chart there that there's certain areas that are high prevalence. So, for example, renal 45%, vascular surgery 62%, respiratory 36%, geriatrics 38%. So there's areas where over half the patients have got diabetes sometimes. There were two areas of interest that has brought this whole insulin safety issue to a head over the past year or two. First of all, an audit of DATIX reports for insulin errors over a 6-month period revealed 34, and looking at these in detail, the reasons for the errors were mainly due to insulin omission, incorrect dosing, or incorrect administration. And there was a slightly scary report that went round recently where the inpatient group had to respond to, over an 18-month period, there were 8 serious clinical incidents relating to insulin errors, 4 involving inpatient DKA, mainly in surgical wards, and 4 severe hypoglycemia, unfortunately resulting in 2 deaths in the elderly. And the analysis of this revealed what we might expect, that there were significant knowledge gaps amongst both doctors and nurses aligned to each of these incidents. So that combination of reports has been the tipping point in raising insulin safety awareness. The SCIs have gone to very high level, to medical director, to governance committees, to operational governance committees, and that has provided the impetus for us to try to think of a strategy about how to start dealing with this. So the challenges we have in GGC are mainly due to lack of education amongst medical and nursing staff. Junior doctors get very little in undergraduate training about insulin prescription and dose adjustment, and then when they arrive in hospitals, it's often the FY1s that are asked to prescribe insulin on the charts. In addition, I was surprised to find that certainly in Caledonian University, where most of our nurses come from, there is no mandatory diabetes education for undergraduate nursing, and we've been trying to work with some of the people in Caledonian to see if we can address this, and I'd be interested in the views of others on that. We did have an attempt to implement Think Check Act in the general wards, but that was one person going around many, many wards, and it really needs a constant presence and reminder to get staff to think about this excellent initiative. The increasing use of pen insulin, especially including concentrated pen insulin, has sharpened the focus in terms of insulin dose errors. I was interested in what Debbie was saying about her very good self-administration pathway, and it's something that we hope to learn from and hopefully implement a similar version in Glasgow over the next year or two. We've suffered from a poor rollout of capillary blood ketone testing, and that's starting to have high profile, especially given the 4 SCIs of inpatient DKA. And it is embarrassing with type 1 patients where we can't check blood ketones, whereas they have meters that can check them themselves. You feel very amateur as a diabetology team. And finally, the lack of resource for the use of linked IT systems to target high-risk patients. We now have joined-up systems, Sky Diabetes, Track Care, glucometer databases, which we can plug in algorithms which will tell us and alert us to patients at high risk who are coming into our beds, and we can maybe get to them before they have their severe hypo, but we just don't have the staff resource to staff this potential resource. I've put a few patient quotes. We did a recent sort of inpatient pilot questionnaire. I'm not going to read them all out for time, but if you look at the third one, somebody was saying, you know, when it comes to my glucose control in hospital, I feel very vulnerable and anxious and just don't have confidence in the system. And I think that kind of sums up what a lot of patients on insulin feel when they come into hospital beds. They feel the controls taken away from them. And that's something that we really need to address and get on top of with education and new pathways. So what have we done in Glasgow? Well, we've set up an inpatient team in the Queen Elizabeth Hospital called Team of the Week, and that's linked into Track Care referrals, and that's a team of consultant SPR and diabetes specialist nurse. We do have excellent response times. Usually we attend within the same day, or at least give telephone advice, and we can get to patients within 1 or 2 hours if urgent, and that's especially for admission avoidance or new type 1s. And we have referral criteria adapted from Think Check Act, which I'll show you. The first 4 there out of the 11 criteria are for the acute urgent cases, new diagnosis type 1, DKA, HHS, and severe hypoglycemia. And we do get to them fairly quickly. We did an audit of the Track Care referrals, and that helps us to understand the reason for those. And you can see that when we combine hyperglycemia and hypoglycemia, that accounts for over 3/4 of referrals to the inpatient team. Many of the referrals with hyperglycemia would not have had to be referred if staff, especially junior doctors, had understood basic titration principles. So that's been that's highlighted the need for education amongst junior doctors. From the audit, we can also understand where these referrals are coming from, and not surprisingly, mainly from medical wards. But 10% are coming from admission areas, and that's very important in terms of avoiding admission, especially over weekends with insulin-related issues, for example, new type 1 walking winded. Interestingly, since we launched the track care referral system and the awareness has been raised, our referrals have increased by 80% over the past year, such that in the month of March this year, we were up at about 180 referrals for the month. The problem with that is that our staff resource hasn't increased. We've still got the one consultant, the one DSN, and the one registrar, and we're struggling to cope with that. My colleague, Chris Sainsbury, who you may have heard of, is a whiz kid with numbers and number crunching, and he has a database of many years of the glucometer system, and we can very easily see in any area or groups of wards what the hypoglycemia rate is, whether the hypos have been effectively treated or not, and what the timescale of that is, what time and range for blood glucose for any individual patient, variability. We can even extrapolate length of stay. And over and above that, we've started looking at patient surveys that I mentioned earlier, and also staff surveys, especially training needs analysis. So we do have data, and we now have a team of DSNs who are working on a project over 2 years with a joint working project with pharma company, where they're going to be looking at some interventions and measuring whether education and intervention in ward areas improve some of these outcomes. The tip of the iceberg is such that we know that from looking at the NADIA data in England and Wales and the reasons for referral to an inpatient team, if every ward in our hospital followed that to the dot, then our referrals would go up by 4 or 5-fold. Now, this would be appropriate referrals, but clearly our staff resource is such that we can't deal with that. And if we extrapolate the average inpatient DSN for England and Wales to our situation in southwest Glasgow, then we would actually, for covering 2,200 beds, we would need 6 or 7 DSNs, and we currently have 1. So any ideas on that would be gratefully received. What else have we done? Well, the focus really has to be on education, and thankfully we've managed to persuade the people that organise the junior doctor e-induction, which is mandatory, to include a significant chunk on insulin safety and things like insulin dose titration and what you do at midnight with somebody whose blood glucose is 21 and so on. So these hopefully will be read and listened to by junior doctors arriving in GGC at all levels, and this will hopefully improve doctor prescription of insulin in the general wards. As part of our joint working project, we're hoping to devise a rolling program for ward nurses, which will include modules on pen insulin, especially the new insulins, concentrated insulins, working with safety needles and reduction of needle stick injuries, and also focusing on our top 10 tips campaign, which I'll mention in a minute. We're currently doing, or have just completed, a hypobox check and audit across the Queen Elizabeth Hospital, which has thrown up some useful information, and we can correlate that with the hard glucometer data to see whether there is a correlation between how hypoboxes are managed in the wards and how hypos are treated in the insulin patients. And that's something that we're currently doing. Last year, we were horrified to realize that there were 18 different charts for sliding scale insulin in GGC, and so we put together a new guideline and a new chart, which we're currently piloting, and that's hopefully going to be implemented in GGC in the autumn. We are hoping to collaborate with Debbie, who you've just heard from, on pilot an insulin self-administration pathway based on the Tayside model. And we are starting to persuade the powers that be to fund the phased implementation of capillary blood ketone testing, especially in high prevalence areas such as admission units, HDU, the diabetes wards, vascular surgery, and so on. Of course, we need to then also put in an education program, because simply checking a blood ketone isn't much good if you don't know what to do with the number, and that's providing another challenge. And we want to, as part of the joint working project, pilot a project to look at the linked IT systems and see if we can intervene early in high-risk patients and improve the outcomes that we can measure. So I mentioned the top 10 tips, and this is something that we use during Insulin Safety Week to try and focus the minds of ward staff on areas that we thought would be useful to drum home, and we're going to continue to do this. So I'm not going to go through them all in detail, but the first 5 are on this slide and the next 5 are on the next slide. So effectively making sure that the insulin dose that's written up and the frequency is correct, checking with different sources, using pens rather than switching to syringes and vials is the way forward. But obviously reducing needle stick injuries with pen safety needles is imperative as well. As Debbie said, we need to be using charts with units pre-typed, never writing U or IU after the number because that can be a disaster. And really trying to educate doctors and nurses and pharmacists that almost everybody that comes into hospital on insulin will need a dose change for various reasons. Very few patients will have the same dose prescribed all the way through the hospital admission, especially acute medical admissions. In addition, really pressing home the message about continuing basal insulin in a type 1 patient, even if they're fasting or nil by mouth. And that's really important for preventing inpatient DKA. And again, linked to that, ensuring that basal insulin has been given before discontinuing IV insulin. Bit about patients coming in on pumps, because increasingly there's more pump patients around. And focusing on the concentrated pen insulins, raising awareness, the never event of drawing insulin from a pen with a syringe to give to patient, because that could end up giving 2 or 3 times the dose of insulin. And a little bit about the combination injection products, of which there are currently only 1, but I suspect there'll be more on the horizon. So what have we been successful with so far after this tipping point of insulin safety? Well, we've certainly raised awareness of insulin safety issues at a very high level, medical director level, operational governance, senior clinical governance meetings, SUM, and so on. We've managed to get the track care referrals up and running, and we're managing the workload as at present. But of course, as we raise awareness more and maybe get more referrals, then we may not be able to cope with that extra resource. We've managed to get the VRI pathway piloted and hopefully implemented this autumn. We've got the insulin safety module on junior doctors e-induction. We've done the hypobox audit and hopefully improve the use of this, and we're making steady progress with ketone testing. Things that we're still struggling with is how to engage busy nurses in a ward setting in insulin safety education. And as I said before, we just don't have the staff to utilise the information that's available from the linked IT systems. So in summary, I've shown a series of Datix insulin errors and serious clinical incidents that have been the tipping point for insulin safety awareness raising in GGC. Attempts to respond to this have been challenging within a neutral budget resource, and responding to referrals is only the tip of the iceberg of inpatient insulin issues. Education, education, education is the key message, and we're exploring innovative methods of upskilling HCPs involved in insulin prescription administration, including the Top 10 Tips campaign. Areas we would like to learn from others, ideas on how best to reach ward nurses for insulin education, insulin self-administration protocol experience, and many thanks to Debbie for her excellent advice on this, and also how best to utilise the linked IT systems to identify the high-risk patients. And that's me done. Thank you.
Thank you, Steve. It's been really great to hear today from 2 different boards about the work to make insulin use safer. We're now going to unmute all the lines, and I'll now hand over to Arvind for the question and discussion section.
Thank you very much.
Your line has been unmuted.
Thanks, guys. Really helpful. I've learned a lot from both presentations. I've seen some questions in the chat box, and Firstly, does anybody have a question that you want to raise before I pick up from the chat box or other questions? Any questions or comments, anybody? Okay, so I'm going to ask Lynn McDonald to, Lynn, are you there? Are you able to ask your question for Debbie, please?
Hello, yes, can you hear me?
Yes, we can, thank you.
Thank you. Well, I just moved to NHS 2 years ago, but when I left Grampian, I was aware that there was a national insulin chart in preparation, and I just wondered how far on that was.
Well, the insulin chart for the being mooted as a national exemplar was the insulin chart from Tayside.
Yes.
But unfortunately, we were just very slow in getting it passed and getting funding for testing. So we've now managed to successfully implement the insulin prescription chart here in Tayside. That was in last June. And I know that a few of the other boards have something a little similar to the insulin prescription chart that we're using here, but we don't have such a thing as a national chart. We're very happy for anybody to adapt our NHS Tayside chart, though, nevertheless.
Great. Thanks very much, Debbie.
Thank you.
Thank you, Debbie. Any other questions? Anybody else? Debbie, can I ask you a question too? So in Lothian, we're looking at the Tayside chart and use it. One thing that wasn't clear to us, for each of the spaces, the breakfast, lunch, dinner, you have 3 columns in which you can input blood glucose measurement, for example, and presumably the idea is that if it's low and they measure further blood glucose values, then you can put that in. What do nursing staff do if there's more than 3 measurements at that time period?
So they would just extend and put the time along the top. So what we argue is that there's 12 boxes across one day to document blood glucose monitoring, and if they're using 12 boxes, there's clearly a big problem with insulin management. So that shouldn't happen too often. But the nursing staff will just go on to the next box and put the time in.
Excellent.
Occasionally it does look a little bit like a graffiti board, but many of the charts you can just see the trends of the breakfast, lunch, tea and supper time blood glucose levels. So when the insulin prescription is good, the charts are much tidier.
Thank you. Like, any other questions?
Oh, I was just curious, and I have typed it in the chat box, and I guess it's a question to both Steve and Debbie, and it's around other models of training, and just wondering if there was any simulation that you're aware of that would actually involve team building around managing a hypo.
From me, not that I'm aware of, but would certainly be interested in others' experience of that.
As part of the Kuwait project with University of Dundee, we do a clinical skills scenario with hypoglycemia, but it's basically a scenario where somebody's hypoglycemic and the students are asked to recognise the hypo, manage the hypo, and then discuss the ongoing management. It's always very popular with the Kuwaiti students, but we don't do the same here.
So is that almost like a tabletop exercise rather than an in-situ kind of simulation?
Yes, it's done in a clinical skills area.
Right, okay, well, that's great. And so I've just seen too, and Lindsay Lawless, it's great to have you on board. I've just noticed you've noted in the chat box that you're looking at simulation events. Is there anything that you could add to that at the minute in terms of where you think you're going with that?
No, I just mean simulation events in general within Ayrshire and Arran, because participating in the WINS and Lanarkshire, we've found these quite fantastic events. So we've been linking in with our medical simulation team, but the hope is obviously to include areas of prescribing and high-risk medicines, and insulin would be one of them.
Absolutely.
So it's in the area, very early stage development at the moment.
Okay, thanks Lindsay, and thanks for putting that in the chat box.
No problem.
Thank you. just interrupt me, anybody else who has a question, but I'm going to ask you all to do something. I'm wondering how many of you actually have experience of a chart like this with a lot of guidance on insulin prescribing. Perhaps you could write in the chat box your different experiences in different boards maybe. But does anybody else want to talk about experience with a different insulin prescription chart? And particularly how your experience compares with what we've heard today in the WebEx. Okay. While you're mulling on it, Steve, a question for you. I was really interested when you said that you're collecting data on the glucometer results in relation to the reliable use of the hypobox. I would love to see whether the glucometer data have been used before for any other such QI work. Are you aware of anything?
Yeah, Chris Sainsbury and Greg Jones have published fairly extensively using the database, because we can see not only if a patient has a hypo, but we can then see how long it is till the next blood glucose check, and that gives a measurement of understanding of the protocol. So if it's 15 minutes, that's fine, but often it's 20 minutes or half an hour or even an hour after the hypo event before it's repeated. And also the second measurement is if it's still hypo and it's not resolved, is it then treated again, and is it checked 15 minutes after that? So there's quite a lot of quantitative information. You can kind of come up with a hypo treatment effectiveness score as an amalgam of these measurements. And we've been doing that, well, they've been doing that in Glasgow for about 12 years. So there's many millions of data points on Chris's computer.
Wow.
In NHS side, we have electronic links between the connected blood glucose meters, Track Care and Sky Diabetes. So we have reports coming through to the specialist team on a weekly and monthly basis as to all the episodes of hypoglycemia across the NHS side, the wards that the hypo occurred in, and the resolution rates within 1 hour. So our challenge is sharing this information with ward staff, because it's only seen on Sky Diabetes. And we as diabetes specialist nurses can virtually review patients because of this linkage of the connected blood glucose meter. So if the blood glucose meters are docked in the ward, we can do real-time surveillance of blood glucose monitoring, so we can troubleshoot where people are hypoglycemic and be more proactive.
Fantastic. Thank you very much, Debbie. There's a really interesting question from Fiona, Fiona Needleman, which I think somebody else in this group should be able to answer. Has the implementation of HEPMA impacted on the use of insulin prescription charts, and how has it been? So thank you for that, Fiona. Any answers? Oh, there, Anthony.
I could chip in from a HEPMA point of view in Ayrshire and Arran. So in Ayrshire and Arran, our insulin is prescribed on HEPMA as charted, and we use a supplementary insulin prescription chart. So unfortunately, we have very similar problems to what Debbie highlighted in Tayside with prescribing on the supplementary insulin chart. And then we actually have further problems in that, because it's the insulin is prescribed on HEPMA as charted and also in the supplementary chart, that quite often the two prescription systems don't match up, and then we have discrepancies in the insulin that's prescribed and also the dose units and things. So we have that additional problem now that we have HEPMA as well as the supplementary charts, I'm afraid.
Yeah. So can I just double check, and thank you for that reflection, Lindsay. We as a medicines team had gone around and visited the other two boards that have implemented HEPMA, and I know, Anthony, you've noted the plans in Lanarkshire, and it sounds like there's a similar short-term plan with separate charts. But can I just check, is there anyone on the call from Dumfries or Forth Valley before I answer on your behalf? Is there anyone from Dumfries or Forth Valley that can answer the question regarding HEPMA and insulin?
Hello, it's Leslie Johnston here. I'm from Dumfries.
Hi, Leslie.
Hi. I was just actually replying to it about HEPMA there. I was listening to the comments. HEPMA does, as the previous lady suggested, the problem, because it is really giving us the line as charted, and as nurses using that in the acute sector, still the problem of issues being raised when it's not documented clearly, or the documents are lost, misplaced. So there still are the issues, although HEPMA is there to prompt a nurse to look into the administration of insulin. There's still a paper copy that needs to be found and used for actually administering the insulin.
Yeah, thanks, Leslie, and I think that was definitely our findings as well when we went to Forth Valley. It does seem, in the short term at least, any of the variable dose medicines or those that are considered a bit more high risk with an existing specialist chart, they've not necessarily been translated into the electronic environment yet. So it is the as charted and using supplemental paper copies. That's certainly something that we did see when we went around the boards, and please do correct me if I'm wrong, but that's the experience we kind of picked up when we visited the boards.
Thank you. I'm aware Lorraine's going to come back and just tell us about the next few sessions in a few minutes. But are there any other burning questions or comments from anybody? It's been a really useful learning exercise. I've seen a lot of stuff that's really new to me, and I think my team and NHS Lothian have already been looking at this. They're really interested, and I see Gillian's on the call as well. I'd love to know what people in this meeting have taken away. It'd be great to hear what you're going to test or try. Please write to us later if you like. It doesn't have to be at this meeting. And I'm going to hand over back to Lorraine now to finish the call.
Okay, thank you, Arvind. So as a team, SPSP Medicines are focused on the 6 drivers for change that were identified as part of our stakeholder exchange earlier in the year. We are committed to these as core themes of our work, and it was clear how today's presentations relate, particularly in terms of work processes and education. We are delighted to have a full schedule in place for the rest of our 2018-19 WebEx series. In August, we're excited to be joined by colleagues in Northern Ireland who will be sharing their work around supervision for safer prescribing. Our own SPSP Medicines team will be presenting in September to share with you our work today around bleeds associated with medicine use. And in October, we are very pleased to be joined by the Excellence in Care leads from NHS Greater Glasgow and Clyde, NHS Western Isles and NHS Orkney. We have been collaborating with them around improvement work to reduce medicine administration emissions, and this work will inform the relevant Excellence in Care measure. So we're very much looking forward to the opportunity in October to share this work with you. At the present moment, we aren't able to post any new information to our website, but we will be sending out our pre-WebEx information and joining details for the August event soon, and this will go to all of our key contacts. If you're not already on the list and you would like further information on this or any of our WebEx events, please get in touch with us at the email address that you can see on your screen at the moment, and you can also follow us on Twitter, and we post information about our WebEx events. So thank you all again for your time today. I'm sure you'll join me in saying we're hugely appreciative of Debbie and Steve's time today, and we hope that you'll all join us again on the 16th.